in this population, but for lower demand patients who are not ready for surgery, then that's great. There is one algorithm published on addressing post-traumatic arthritis operatively, and I think it's a useful way to sort of organize it, and that's sort of how the chapter organizes it as well. So your operative options for post-traumatic arthritis are really osteocapsular debridement, whether that's open or arthroscopic. There's interposition arthroplasty, there's radiocapitellar arthroplasty, there's total elbow arthroplasty, and there's elbow arthrodesis. And the book chapter runs through sort of the techniques and setup for each one of those different options. I pay a lot of attention to the arthroscopic osteocapsular debridement in the chapter because I think the learning curve for that is by far the highest out of those techniques. And then it runs through sort of the decision making. When do you pick arthroscopic debridement versus an open debridement? When do you pick total elbow arthroplasty versus an interposition arthroplasty? I don't think these are necessarily clear-cut decisions, but I present to you my thought process and the thought process that's available in the literature for addressing those. And then I try to provide some specific cases and clinical photos that help with the setup and small technique tips for each of those procedures and how I carry them out. So that's sort of how the chapter is set up for me. I hope you really enjoy it. I think it'll be a useful part of your practice if you're tackling these challenging post-traumatic elbow cases.
Thanks so much, Kevin. So, as Kevin outlined, these chapters are structured very similarly in the fact that each author has given us their insight into diagnosing the condition, into how they look at radiographs or advanced imaging technologies, how they also come up with an algorithm on how to manage these injuries from the non-operative end of the spectrum all the way to the operative techniques. So the unique part about this book and the unique part about these chapters is that you go from that entire gamut of non-operative management and then surgical tips and tricks for each specific joint in terms of setting up the patient, in terms of some of the equipment needed, the portals that you may need to access the elbow if you're going to scope the elbow versus open the elbow. So it's very unique in that perspective because you can really get up-to-date information on traumatic or post-traumatic arthritis, not just general run-of-the-mill inflammatory or degenerative changes. And it also gives you pretty good tips and tricks on what to do with the hardware if it exists, or any kind of orthopedic prior hardware or prior screws, plates, and how to deal with that as you manage the soft tissues in the bones. So with that being said, I'd like to now hand it off to Ajit Deshmukh from NYU. Ajit has been a mentor and a close friend, and he trained me when I was a fellow up at NYU. So over to you, Ajit.
Thank you, Savya. First of all, I would like to thank Savya and Eric for the opportunity to participate as an author on this book, and also Ashok for putting us on this platform. Well, the chapter is focused on post-traumatic arthritis, after distal femoral fractures. And, really the bulk of the work has been done by my co-author, Karthik, who was a resident at that time. And, we again go through the entire, gamut here. The chapter actually starts with the epidemiology, where we, note that these injuries are typically found in, two different population groups. The elderly population, wherein these fractures do occur with, low energy trauma or low energy mechanisms. And then, the younger population where these injuries, distal femur fractures, do occur with, significant high energy type of mechanisms. And, we go on to basically discussing the natural history of healing of, different management options. When the trauma surgeon is handling these fractures in the acute setting. So, retrograde intramedullary nailing, plates and screws, different types of locking plates, blade plates, and all these make up for the treatment of these fractures in the acute setting. Although these fractures heal pretty well because of the cancellous nature of the bone, we note that there is a high risk of post-traumatic arthritis in this particular type of injury. It could occur due to mostly a malunion, which would happen at the distal femur, which later, after a couple of years, will result in abnormal loading on the joint and post-traumatic osteoarthritis. Also, post-traumatic arthritis can happen due to cartilage damage, which can happen initially at the time of the injury when the cartilage is banged up. Intra-articular fractures have a higher risk for developing post-traumatic osteoarthritis, and there is a study which we have discussed here which found that if the intra-articular step-off is more than the thickness of the articular cartilage, then the chance of developing post-traumatic arthritis is really, really high. Then we go on to the evaluation of the patient, which starts with a very detailed history and meticulous clinical examination, looking very carefully at the alignment of the limb, the range of motion of the knee, any previous incisions, radiographic assessment in the form of, standard knee x-rays, which include weight-bearing AP, lateral, oblique, sunrise, and tunnel views, and sometimes advanced imaging in the form of CT scans. The management of these fractures is discussed further on in the chapter. As with any post-traumatic arthritis or primary osteoarthritis, the non-operative management consists of, conservative management in the form of anti-inflammatories, acetaminophen, weight loss, activity modifications, knee bracing, assistive devices, physical therapy, and injections. There is no consensus between whether viscosupplementation or corticosteroid injections will provide relief, but both have some value in management of post-traumatic arthritis, just like primary osteoarthritis of the knee. The operative management is discussed further on, and it varies from just some small osteochondral allograft, which can be used for focal osteoarticular defects in the knee. And there are some case series which suggest that there is a 95% survival at 5 years if as provided these operations are done in the correct patient. Younger patients with focal osteochondral injuries can be treated with this particular type of treatment. And Alan Gross up in Canada has done a lot of work here. For end-stage post-traumatic arthritis, obviously arthroplasty is the best option, and we discuss some literature here. We also discuss how the risks after total knee arthroplasty is much higher in this particular population compared to total knee arthroplasty in primary osteoarthritis. And I think, needless to say, this probably happens due to the presence of previous hardware, presence of intra or extra-articular deformities, ligamentous instability, and prior incisions, and so on and so forth. We have also discussed how primary total knee arthroplasty can be considered in a select group of patients, people who are really elderly, low demand, with absolutely poor bone quality, and people with underlying osteoarthritis already. These are the patients who could be considered for primary total knee arthroplasty in the acute setting when they present with comminuted distal femur fractures. Again, the type of total knee arthroplasty varies from simply constrained condylar type of total knee arthroplasty to a hinge type of total knee arthroplasty to a distal femur replacement. And this has been a topic of some controversy, but there is enough literature to suggest that in the acute setting, this is really one of the options for a select group of patients. We then go on to discuss total knee arthroplasty, of course, as well as osteotomies, extra-articular osteotomies for the management of this condition. When you are presented with a younger patient without significant osteoarthritis, without bone-on-bone osteoarthritis, with significant deformity and knee pain, then an extra-articular deformity correction surgery can be planned. Much like what we do in the varus knee, with high tibial osteotomies, something like that, we can certainly consider distal femur osteotomies. And the literature has pointed that this is a viable option in the management of post-traumatic deformities before the onset of significant osteoarthritis in the knee. The bulk of the chapter from this point is focused on basically a total knee arthroplasty when you are faced with a setting of post-traumatic osteoarthritis. Again, here, attention to detail is necessary other than adequate imaging and meticulous clinical examination. The range of motion of the knee is really sometimes very limited in these situations, and there are multiple prior incisions which the arthroplasty surgeons has to look out for. Sometimes this may need help of a plastic surgeon to achieve closure. The exposure, you can typically need some type of extensile exposures like a quadriceps snip or even a VY turn down, or even a TTO or a tibial tubercle osteotomy if you want to preserve the extensor mechanism. Different types of constraints are available in the armamentarium for a total joint surgeon here, and these include routine cruciate retaining or posterior stabilized knees, and from here it goes on to constrained condylar and the hinged type of total knee replacement setting. Most commonly, the hardware which has been placed is a matter of concern. These people typically have a higher risk of infection, and you must rule out infection with inflammatory labs prior to taking the patient to the operating room. Some of these screws and plates or intramedullary devices can be preserved by using navigation, computer assisted surgery, or even imageless navigation, so that you don't have to put an intramedullary guide in the femur, since there is hardware there. But you also have to be mindful of whether you are going to need constrained and a stemmed implant. If you need a stemmed implant, then you will have to take out some of the hardware, and that is what we have discussed here. A literature review has been provided, and concomitant deformity correction of an extra-articular deformity along with a total knee replacement has also been discussed. Also, pre-operative planning, you need to draw your lines and see if your deformity can be corrected intra-articularly, or whether you need to go to an extra-articular deformity or osteotomy to be able to achieve the standard alignment. If you are able to achieve the alignment with standard bone cuts intra-articularly correcting the deformity, then that is the best case scenario here. You don't have to do anything extra articular. But if you feel that based on your templating that your intra-articular bone cuts are going to compromise the attachment of the collateral ligaments, then obviously an extra-articular deformity correction can be planned, which could be done in a staged setting prior to a total knee arthroplasty, or at the same time with the use of longer stems and additional hardware. We have discussed two cases here. One case is of a person with a supracondylar malunion, and this was treated with a corrective osteotomy, and the patient did actually very well for about 5 years until eventually he needed a total knee replacement, which we did recently. And then another patient who had approximately a 45-year-old fracture with significant deformity, but this could be corrected through intra-articular bone cuts. So we just chose to do a constrained condylar total knee type of arthroplasty, and the imaging is presented in the chapter. So that's it for as far as our chapter is concerned. I think this gives a broad overview of the epidemiology, the management, clinical examination, and the necessary imaging, and then some surgical pearls about how to manage these cases.
Absolutely fantastic. Thank you so much, Ajit, for the detailed overview of the chapter. I mean, as Ajit pointed out, it covers a lot of facets, a lot of intricacies associated just with the distal femur. So you can begin to get a picture. We can talk about proximal tibia, we can talk about the proximal femur, the acetabulum, so on and so forth. So we've really taken a lot of attention to detail when it comes to these individual joints. I have the book here with me, and just kind of flipping through it, it has a lot of images, a lot of pictures, a lot of text associated with it from various different angles. So I encourage each and every one of you to try and browse through this. At least you can get a free preview as well on the Springer website or on Amazon. With that being said, I'm going to show you a few snippets from our chapter with the acetabulum. Once again, I'm going to share my screen. And just a brief overview about what's different about a complex primary, especially when it comes to the acetabulum. You have to think about the bone stock, both in the acetabulum and the femur, and then you have to also think about things like soft tissue balancing and soft tissue issues. So some of these cases are courtesy of Eric Hassenbohler, who has been my co-author on this chapter. We also kind of address the spine-pelvic relationship. We discuss the acetabulum in terms of a revision acetabular setting, with acetabular bone stock being defined by the PAPROSKY classification. We show you pictures of what these different types of defects are. And then we go on to say that, there are really two ways of correcting these deformities, in either a defect matching or a defect bridging type platform. And then we present you cases such as this case of a patient with bilateral protrusio. This was just an idiopathic protrusio case. We show you some templating images and the final correction that occurred in this patient. And then we also show you patients who have traumatic protrusio. So bilateral acetabular fractures caused by a traumatic situation in which we waited for consolidation to occur. As you can see by these images, I know that some of them are a little bit blurry and a little bit smaller on this presentation, but the book gives you a beautiful overview of how this consolidation occurred. Then we give you an intraoperative pictures of how exactly the deformity looks like, how you can go ahead and obtain bone graft from the femoral head, the instruments that you need, and then how you apply that bone graft in a beautiful shell that you create, and use a multi-hole cup to try and correct that acetabular fracture. And here you can see the final radiographs of the final outcomes for these patients. Along with these cases, we also discuss cases of true acetabular fractures and acute total hips and acetabular fractures, as this is an example of a complex fracture. We show you how we plan for the fracture correction with three-dimensional reconstruction. Again, this is the part which I enjoy the most, because as Eric mentioned, Eric is an orthopedic trauma surgeon. I'm a hip and knee reconstructive surgeon. So it really bridges our knowledge bases, where Eric fixed this fracture, and then we went ahead and we performed a replacement at the same setting to afford the best possible outcome for the patient. And then when you have patients such as this with massive acetabular defects, again, these are cases that I really learned from Ajit on how to manage these things, like performing figure of 7 allografts or autografts in these patients, and then correcting that deformity, bringing that hip joint center back to its native center of rotation, and then giving them adequate offset and leg length correction. Finally, we also discuss challenging cases such as this, such as pelvic dysmorphism, in which you not only have a dysplastic acetabulum, but you also have SI joint fusion on that left hemipelvis, as you can see by this three-dimensional CT, and this massive deformity, and how we try and approach this with three-dimensional bone modeling in identifying the structures first off, and then finally correlating that with our intraoperative pictures and intraoperative anatomy that's observed in the patient. We go ahead and we show the various degrees of version that are associated with the acetabulum and how we can correct that. And finally, this is the outcome at 2 years. So if you have the online version of the book, you have access to some of these pictures and some of these videos, and how patients perform after these massive corrective surgeries as seen here. So with that being said, the final case that I think I wanted to highlight was, we also discussed pelvic discontinuity. So we discussed how we, initially were bridging the gap. We have concepts such as distraction osteogenesis that we've discussed in this. And we've also discussed the use of custom devices such as a TRIFLANGE, as shown in this case. and I'll show you the images associated with the failure of a cage in a traumatic situation, and then the application of a custom triflange and restoration of the center of rotation. Once again, these are the offers that are currently available to us. The link will give you a $40 discount, and then the holiday sale, which is up to December 31st, will give you an additional $30 off. So it's a great offer. Please make use of this. This is our contact information. Please feel free to email us with any questions or concerns that you have. And once again, thank you very much to Ashok for hosting this first book club for us. I'd like to stop my screen share. Ashok, if you'd like to say any words, or my co-editors, my author, if you'd like to say any words, please go ahead.
If I can, thanks Savya for this great presentation of the book chapter and the acetabular fracture. Thanks Ajit, and thanks for Kevin. The book, as I mentioned before, is kind of a missing link for things that you may find in bigger academic books, but it's a summary of specific cases that once in your life you're going to be confronted with. And each of the authors in the book have given time and spent time to handpicking the right example. And there are great pictures in the book from each chapters to demonstrate challenges that you can face and how to face those challenges when you have this patient coming to you. And as they've both Ajit and Kevin in positioning and preparation and methodological processing of the procedure. But those are each of the chapters, again, I say, is specifically kind of handpicked and goes into details. And I consider this book, even though it's kind of a thin book because there's not much in the literature, if you can see, but it is an international book. I consider we invited authors also from Europe to give in their perspective, in their expertise. So Savya and I are very pleased about this, and hopefully you all will read it through it.
Awesome. Thank you very much. And I'm seeing these chat messages from Ashok about the discount link, so I'll definitely get that to you so we can share that with the OrthoTV online community.
If I may add to it, I think it was an excellent beginning with a very, very beautiful book for our Ortho Book Club. Like mentioned by Eric, this concept has never been covered in a book format, and I think this will be one of the ready reference for anybody who is going to be facing this situation in clinical practice. So, I think the readers will be really thankful to all of you authors who have compiled this for all of us. So, about the session today, I think this was a really great beginning. Me and Savya were wondering about how the format should be and how we should go about, because there is no current format for such kind of book club existing. So I think we laid down the foundation of how it should be, and I'm sure future authors and many more who are ready with a book, writing a book, or even have written book in past will be holding a book club in future for us. So thank you very much. I think this is a great beginning for our first book club. Thanks a lot.
Thank you. Bye-bye.
Thanks.
Thank you, Ashok.
Thanks a lot. So
Thank you.